Hi, everybody. Thank you for joining me today. My name is Liana Manise, and I'm going to be talking today about personality disorders. Particularly, borderline personality disorder is going to be my focus. We are going to touch on some background and history, prevalence, an overview, diagnostic criteria, risk factors, methods for diagnostics, cultural and ethical considerations, treatment modalities, and then it'll follow up with some of my citations. So I just wanted to take a second to talk about personality disorders as a whole. And so an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. This pattern is manifested in two or more of the following: cognition, affectivity, which is like range, emotion, intensity, appropriateness, and interpersonal functioning. And it's kind of like this intense impulse to control. So that being said, there are three clusters that personality disorders are split up into. So like I said, I'm going to kind of just touch on them, but we are going to focus on borderline personality disorder for the rest of this presentation. But cluster A includes paranoid personality disorder. And in parentheses here, you can see, I'm going to mention it, but I kind of just, tried to figure out, what two words really helped me to sort of grasp some of these differences between these personality disorders. And so for paranoid personality disorder, I chose distrust and suspicion. Schizoid personality disorder, detachment from social relationships. Schizotypal personality disorder, social and interpersonal deficits, distortions, and eccentricities. Eccentricities is kind of something that we see moving throughout this, through all of the personality disorders. And we also talked a lot about it when we had the conversation about schizophrenia as well. So eccentricities, this sort of like deviation from the norm, which I'm going to go into a little bit later as well. But I think that's just a huge piece of this that is what sort of sets this apart. Cluster B includes antisocial personality disorder, a violation of other space and needs. This can start around 15 years old. And borderline personality disorder, which we're going to be talking about today, which is like instability and impulsivity. It starts off in early childhood. Histrionic personality disorder, which is focused sort of on attention seeking. Narcissistic personality disorder is this grandiosity, need for admiration, starts in early adulthood. Cluster C, avoidant personality disorder, social inhibition, a deep feeling of inadequacy, and hypersensitive, very, very sensitive, and that starts in early childhood. Dependent personality disorder is a pervasive need for care. It's sort of a submission state of submission, excuse me. And that starts in early childhood as well. Obsessive compulsive personality disorder, which, patterns of orderliness, perfectionism, and again, coming back to that sort of need for control. And that's definitely something that we see that kind of carries through all of the personality disorders. All right, so, okay. So some background and history here. I just kind of did it linearly, so we could kind of trace it a little bit easier. So 1938, Aldorf Stern lists most of the diagnostic criteria and calls the group of people affected the borderline group. And Stern is kind of the name that we see most associated with borderline personality disorder as we research it. It comes up over and over and over again. Gregory Zilborg in 1941 described the disorder as a mild version of schizophrenia. I find this, like, studying this pretty interesting right after we did our section on schizophrenia. There are some symptoms that did seem to overlap in some things, but honestly, I mean, I see this, a lot in a lot of a lot of different sort of spaces. There seems to be a lot of overlap, but I did find a lot of research also on sort of comparisons and conversations just between studying schizophrenia and borderline personality disorder. Helene Deutsch, sorry if I got that wrong, but I think that's right, defined a type of people dependent on other personalities as having as if personalities. And then in the 1940s, Robert King introduced ego psychology and describes patients as being in borderline states. I think this is an important piece too, because when we think about, like, just the word borderline, it's very heavy. There's a lot there. And I think that also it leads to a lot of other assumptions and movements within other spaces that don't actually have to do with borderline. So we'll talk about that too in a bit. So by 1968, Roy Grinker does the first research on borderline personality disorder, which is very important. So you can see too that this is not something that we've been studying for a very, very, very long time. This is all relatively recent in the scheme of things. By 1975, John Grunderson published research to help diagnose BPD. In 1980, BPD is included in the DSM-3. 1993, Marcia Lenin introduced dialectical behavioral therapy as an effective treatment. I am a humongous fan. I also do this therapy myself. I think that DBT is extraordinarily helpful for so many things. In fact, I probably would recommend a lot of people do it, even though, I've seen it be really effective for everybody to just kind of work through, just really thinking about our behaviors, whether it's something kind of more simplistic, all the way to something very complex like borderline personality disorder. So I think that's what is fascinating in the treatment of this that we will go into later. The DSM-5 is published 1994. Defining further the symptoms of BPD required for diagnostics. I paused because I just realized that I don't remember what IV stands for. I'm like, is that 4 or 5? I think it actually is 4. So there's that. I apologize. I haven't studied Roman numerals in quite a while. So 2008, the U.S. House of Representatives declares May as the National Borderline Personality Disorder Awareness Month. I'm not a huge fan of those kinds of things, months, and I don't know how helpful or focused they can be, but it's a big deal because, it's starting to be recognized in a much broader way. And then currently thinking about borderline personality disorder with more compassion and understanding. Borderline personality, it's like we can see sort of these social constructs in lots of different places societally, the way that we talk about illness in lots of spaces is really problematic, to say the least. So, we're just like, I'm so depressed, and, definitely like, that girl's crazy. She definitely has borderline, right? I mean, it's like we have, sort of, simplified these very complex issues, and I think really prevented a lot of people from getting the help that they need, and us taking things seriously and being compassionate for others, but then also having compassion for ourselves as we move through trying to heal. And so this sort of what I think when I discuss in treatment, they call it sort of this third wave way of thinking that's really, you know, DBT fits into, but just this mindfulness piece, and, you know, just starting to think about things in a different way. So I think that that is important. And so we'll see how that moves. All right. Prevalence. BPD has a lifetime prevalence of about 6%. The general population, it estimates to the point that it's about 1.6%, and the lifetime prevalence is 5.9%. Studies in clinical settings found that borderline personality was present in 6.4% of urban primary care patients, 9.3% of psychiatric outpatients, and approximately 20% of psychiatric inpatients. The ratio of females to males, also interesting with the disorder, is greater in clinical populations than it is in the general population. But the ratio is 3.1, or I'm sorry, 3 to 1 in clinical settings. Surveys in the United States, there's some of the general population, but have found, you know, sort of lifetime prevalence of BPD does not differ significantly between men and women. However, we do see the numbers are much, much higher with women, but also sort of groups that are societally and systemically suffering. You know, because it's something that can be developed in, you know, early adulthood, when we're just kind of starting to figure out more complex relationships, we can start to see some of how these things might add up. But we'll go into that. But, you know, 8 to 10% end up committing suicide. This is the thing about borderline, again, because it is so stigmatized in our society, and people don't take it seriously. We write it off. We push people away. And oftentimes people are not getting the support that they need. So we do see suicide being, also self-harm, as being kind of, you know, staples or something that must be considered when we're talking about borderline personality disorder. You know, what's going on with self-harm, what's going on with thoughts of suicide or ideation or attempts. And just really making sure that we're pulling that out from our clients. So a little bit of an overview, sort of psychosocial causes, which is how I like to kind of look at everything. But a history of childhood trauma is common in patients with borderline personality disorder. However, the relationship between abuse and BPD is not totally clear. Childhood trauma is not always present in patients, and many individuals who suffer abuse do not develop borderline. But it seems that there's a little bit of some confusion, if you will. It seems that with BPD that there is a lot of argument as to where people are really standing in terms of where the root cause is. There's a lot that's still being uncovered, and so it can be a little complicated because there are many studies that are talking about, you know, how does this come to be? How do people get borderline? Where does it come from? And there's a lot of conflicting space there. So, so I just wanted to bring up both sides of it. The trauma that is often present in the history of patients with BPD can take many forms, including sexual abuse, physical abuse, of course, verbal abuse, other types of neglect, early parental separation and loss, which I think is also something that is important to bring up. I hope you can all hear me. My office is right above a train, so it seems like it's gone now. As an adoptee too, this is a really important perspective for me because I was diagnosed young with borderline personality disorder, and then told by another therapist that that was not the case. And it seemed to kind of plague me. And a lot of people just kind of assumed, you know, adoption, these other symptoms, this has got to be what it is. But it's not something that people want to diagnose early. because, I think there's also a lot, the onset of it can take a while, but also, there's a lot of other things to take into consideration if people are teenagers and have sort of other things that are happening. But adoptees, from my understanding, get diagnosed at very high rates with BPD, when in fact that's not the case. It's often just like sometimes a clear-cut case of post-traumatic stress disorder, but it's kind of an interesting conversation to have when we're talking about like the separation or some kind of, or war or some kind of really traumatic experience. And also those things can go hand in hand. So keeping that in mind, that BPD doesn't operate alone often. It's often mixed up with other diagnoses. A systemic review found high rates of childhood sexual and physical abuse. The sexual assault was reported at 16 to 71%, physical 10 to 73%. That's very high. One large clinical sample, 61% of patients with borderline reported a history of childhood sexual abuse, and 59% reported physical abuse. So these are high numbers. And again, there are some spaces that are, and studies that are kind of saying different things, but I think highlighting both sides is important here because we're really not totally sure exactly where this is rooted. It should be noted that there are many discrepancies, like I was saying, in many reports, but high levels of sexual trauma. And the reality is that there are studies that dispute this, but we have to take both seriously right now because we really don't have a lot of information at the moment. So just bear with me. I just want to make sure I'm covering everything. I also wanted to just bring up too that when we were talking about gender earlier, something that's important is that there are some discrepancies there, but the discrepancies also could be suggesting that that women are more likely than men to seek treatment. And so it doesn't simply mean that there are always, for sure, more women with this disorder, but it also could just suggest that men are not seeking help for anything. But also, these kinds of things show up differently, often for men and women. And then also remembering that, this is coming from like a very heteronormative perspective as well. And that complicates things even more. And sadly, there is, next to no conversation about thinking about like how the gender binary affects borderline personality patients and clients, and it gets very complex. So I think this is a really great place to start to think about even some research in that way. All right. So here I've just kind of compiled some quotes that I think are really helpful. Some of these are taken from the film. I don't know if everybody watched it, but there is a film that was about people's experiences that had suffered from BPD. But, things like, I hate you, but don't ever leave me. This one was really intense. The intensity of a burn victim, like they're feeling with the intensity of a burn victim. When I heard that, I just thought, wow, that's a lot. They're dependent and clingy versus like, super enraged rejection. So it's like, really reacting in a very sort of opposite way, being very, very, very intense. And then kind of, can switch it up really quickly to clingy. And there's no one way to do it. It can go either way. I don't fit in disorder. I feel like I'm going to die. Just being, I just feel like I'm going to die. Conform to what others want them to be. So they're kind of searching for, it's not as simple as like needing validation. It's like they really don't necessarily feel like they know how to be without direction. And then someone else commented, because like I said earlier, self-harm, suicide, very prevalent. Somebody said that cutting was like a cigarette break. It was just in their mind. It was as simple as that. I can't take this. I'm just gonna, just like going outside to smoke a cigarette. I'm just gonna, make make a cut in my arm or whatever it may be. So I think that this is really important. This art here was actually in an article in Fader magazine about borderline, and just kind of this thought about, you know, these sort of two sides of who you are. You know, who are you without it? Who are you with it? How do you, what does it mean, that sort of duality? It seems like there's just a lot of duality for people who are suffering from borderline. Diagnostic criteria of borderline personality disorder. There are 9 criteria. The first one, frantic efforts to avoid real or imagined abandonment. It's important to note that in number 1 and number 4, that you should not include suicidal or self-mutilating behavior that is covered in criteria 5. So you don't want to overlap things here. So just make sure that it's kept separate as you're going through these 9 criteria. The second one, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and evaluation. Really important one, again, is sort of like constant duality. Identity disturbance is number 3, marked by markedly and persistently unstable self-image and sense of self. That goes kind of into that idea of needing others to help sort of direct them. What do you want? How can I be for you? How can I change or alter or exist in the way that others need me to do that? Number 4, impulsivity in at least 2 areas that are potentially self-damaging. Spending, sex, substance abuse, reckless driving, binge eating. A friend of mine, she is a therapist in California and works in eating disorders, and they see this overlapping a lot, and a few other things as well. So I think remembering that this is not often something that stands alone, I think is important when we're thinking about borderline personality disorder. The 5th criteria is reoccurrent suicidal behavior, gestures or threats, and self-mutilating behavior. So all of those things, you know, they can feel a little separate. You know, self-mutilating behavior is, you know, not as severe as, you know, suicidal behavior at times. And so they did put it in one criteria, which I know might seem a little confusing sometimes, but it is all there in the same criteria 5. It's not separated, suicidal, not just ideation, but actual attempts and self-mutilating behavior. They put it together. Number 6, affective instability due to a marked reactivity of mood. So for example, intense episodic dysphoria, irritability, anxiety, usually lasting a few hours, and only rarely on occasion it can be days. Number 7, chronic feelings of emptiness. Number 8, inappropriate, intense anger or difficulty controlling anger. Frequent displays of temper, constant anger, reoccurring physical fights. So just, you know, whatever it is that's sort of that trigger that can take them into another sort of hyper mode. And we can see this sort of overlap in some other spaces as well. So just very intense. I mean, intensity was just the word that just kept coming up over and over and over again. Just very, very, very intense. Everything is sort of this, like we kind of say survival mode in this casual way, but really BPD is a constant survival mode. And number 9, transient stress-related paranoia, paranoid ideation, or severe dissociative symptoms. So you need to have at least 5 of the 9, which we'll talk about when we get into treatment. So risk factors. There were a number of conversations about risk factors, but I kind of decided to focus on these risk factors. Family history, people who have a close family member, such as a parent or sibling with disorder, may be at higher risk of developing BPD. Brain factors, studies show that people with borderline personality disorder can have structural and functional changes in the brain, especially in areas that control impulses and emotional regulation. But it is not clear whether these changes are risk factors for the disorder or caused by the disorder. This is where we get into the brain development, our sort of fight or flight mode, our emotion space, our amygdala, and our frontal cortex, which is really where we seek order and understanding. And our frontal cortex is not totally developed often in early adulthood. So, there's a lot of things tied up here biologically that are happening. So the brain is something that is important to think about. What is overactive, what is underactive, and environmental, cultural, and social factors. Many people with borderline personality disorder report experiencing traumatic life events, such as abuse, abandonment, or adversity during childhood. Others may have been exposed to unstable, invalidating relationships and hostile conflicts. I think this is really very important because, it's borderline. When I read about borderline, I actually get very sad because I get sad when I read a lot of this stuff, but because I don't want people to suffer. But borderline really, the deep suffering that these people are feeling, and trying to understand, where a lot of this is coming from, especially when there's not a lot of answers, is really challenging. Especially in a world where this just makes you just absolutely, crazy in the scheme of how society thinks about borderline. So it's very, very hard to get proper treatment, even to get to that point, because it can push a lot of people away. So with that being said too, we're bringing up this idea of, life events, abuse, abandonment. And earlier I talked about how, there's a lot of conflicts. And I was reading an article that stated that some discrepancies. So 15 studies that were examined the exposure to maltreatment and other trauma, including forms of child abuse, whether it was like parental care, supervision, separation, any traumatic experience really. There were about 15 studies done about the connection between that and BPD. 8 studies found fairly consistent evidence supporting abuse as a risk factor, including associations with physical abuse and verbal abuse. So I think that's an important. 3 of 5 studies that examined, this maltreatment as a composite, this abuse as part of these BPD, outcomes, failed to find an association between abuse and neglect. And 2 studies determined that there was sort of this idea of cumulative trauma, and we should be talking about cumulative trauma. So not that any of this is simple, but not simply, the separation of a parent, abuse, but also that this could build, is what they're arguing, that this could build. So you might have gone through some kind of trauma like that, you're suffering from BPD, or maybe you're on the edge, and then a parent dies, or some kind of, they're calling it cumulative trauma. So I think that is a really important piece of this, just to be thinking about. And I really think thinking about cumulative trauma is something that could, we should really be considering throughout all of our work. All right, so let's see. Methods of diagnosis. So clinical assessments. We must do clinical assessments. We want to collect psychosocial information, what's going on in their lives, their spaces, history, and a lot of BPD is about behavior. So we really want to make sure that we are identifying problematic behavior, that is based on the DSM-5. And like I said earlier, you must have 5 of the 9 symptoms, or 5 of the 9 diagnostic criteria, rather. Completing a thorough review, including a discussion about symptoms, is a must. It has to be thorough. And the interviews have to be very, very, very thorough for lots of reasons, but because there's also a lot of overlapping symptoms that you might see in other kinds of diagnosis. And so we really want to be clear here. Performing a careful and thorough medical exam, which can help rule out the possibility of other causes for the symptoms. Asking about family medical histories. I just want to note, as an adoptee, you should be careful about asking that. How do you ask it? People know I'm adopted and they still ask it. It's like, you just probably want to make sure that you know people's histories, maybe before you have that conversation, or just be delicate about how you have that conversation, for lots of reasons, including any history of family mental illness if they are aware of that. So there are ways to self-report borderline symptoms. There is a self-report borderline symptom list. There are lots of clinical scales, which we probably should be filling out most of them. So depending on what the client needs and what they're going through, client scales for self-harm assessment, such as Reasons for Living Inventory, RFL, which is based on a CBT model. It measures absence of harm and adaptive coping skills. Depression measurement scales, which like self-rating scales, looking at depressive symptoms, cognitive, affective, somatics, interpersonal, and so on. Anxiety measurement scales, and sexual abuse history scales. There is one called BASCA, which is the beliefs associated with child sexual abuse. And that's important too, because, sometimes people have memories of things. They're not sure if things have happened. Their bodies might remember things have happened, but they're not remembering in their brain if things have happened, just in their body. And so just think, keeping all of this in mind as you are going through your diagnosis. And so cultural and ethical considerations, which are my favorite thing to talk about, obviously. So there are many cultural and ethical considerations, and I am quite aware that I have a little bit of a different perspective, I think, on mental health than maybe a lot of people do. I contribute most things to our culture and what it's like to live in this society and what it does to us. So that's my own perspective. But there are many considerations. But I want to draw attention to one that I find, a couple that I find extremely important. But the obvious is racism in our field and also in education. I know that we're not in education, but we're getting an education, but I wanted to bring up the idea of education, because when we're talking about something that's diagnosed in early childhood, we have to consider what happens when young people are in school, because that's the place that a lot of these young people are getting pushed into a therapeutic space. The school is pushing that conversation often first. And so it's really important that we understand how racism, not just in our field of psychology, but also the medical field as a whole, and then how that goes into the system in many other ways, education being one of them. We see many high school students of color criminalized, where there's often trauma and other illness that need addressed. And I do speak with 100% certainty that a young Black woman or girl, or trans person or non-binary student with this kind of disorder, like borderline personality disorder, would 100%, without a doubt, in my experience, and I could pretty much for sure say that they would be criminalized before they are even seen as human enough to receive proper treatment and diagnosis. Working in education for many, many years on the side of research. And there are many nonprofits actually that exist now that are exploring this very thing. How we're using mental health as another way to criminalize particularly young Black girls. And then when you get into more intersections, it just gets even harder. And so I see this happen time and time again, and I just thought it was a really important thing to bring up for lots of reasons. So, okay, so I just want to make sure that I'm touching on everything that I had this planned. So this woman, Christine, she wrote an article on the realities of being a Black woman with BPD, and if it's all right, I'd like to read a little bit of what she said. Being a Black woman, Christine Pungong says, adding an intense extra dimension to being a Black woman. Healthcare is both racialized and gendered, and yet many mental health professionals who I have met seem to find it difficult to comprehend the role racism and sexism can have in causing and worsening certain mental illness. She goes on, sometimes I'm aware of my illness being almost political. The anguish and suffering of Black women is fetishized only when it is in sacrifice. Historically, the value of Black womanhood has rested on our ability to endure pain and silence. Black women are martyred for their ability to silently withstand the violence and injustice enacted upon them. Apparently, it is that which makes us divine. The harm that does to the mental health of Black girls everywhere is traumatic. Maneuvering the mental health system as a Black woman has been tough. You are gaslighted, patronized, ignored, or even completely forgotten about. But still, I naively anticipated that day that I went into the hospital, that the aftermath of my official diagnosis would bring a wave of relief and reassurance. I eagerly awaited the peace of mind, and it never came. So thank you for letting me read that. I just think it's a really important, it's really important when we're doing this kind of work to bring the voices of people who are actually going through what we're talking about. And so that's Christine talking about her experience having borderline currently as a woman in her 20s. And then Connie Won, she wrote Unaccounted Foundations, Black Girls, Anti-Black Racism and Punishment in Schools. This is a really important piece, and there's lots of other research, again, done on the space where education, injustice, and mental health meet. In her article, where Black Girls, Anti-Black Racism and Punishment in Schools, it's a qualitative paper that examines school discipline, policies, and informal punitive practices, including the implications that these mechanisms have on the physical and emotional worlds of Black girls, and all just the fullness of that experience. For nearly 3 decades, she says, racial formations theory, which is a really fantastic theory you should totally read about, should you be interested in that, has influenced ideas, discourses, and political projects surrounding race and racism in America. The theory holds that although race is a permanent feature in the United States, the formation, order, and set of meanings inscribed into racialized subjects are contingent upon historical and political contexts. This framework conceals anti-Black racism as an enduring social order that affects policy outcomes, and organizes the relationship between non-Black and Black bodies. One exemplary social institution, though which it can be seen, is the public education system and its culture of discipline and punitive punishment in the United States. And this paper that she wrote is just really phenomenal and very important. And like I said, I really do not believe that we can silo this work. This is not something we just learn in school. This is not something that we see, that we need to just understand the mind. We have to understand all of these other contexts that we're living within. And again, I think about where I've heard borderline personality disorder in my own life, and in my observations throughout life get brought up, and a lot of them have happened through education in that system. And so we have to understand how a lot of that works in order to really help our clients. So gender differences are also considerations, which I touched upon earlier. A study found overall that women and men with borderline personality displayed more similarities than differences in their cultural presentation, or in their clinical presentation, sorry. Among the variables for which there were no significant differences were there were not significant history of childhood trauma, current psychosocial functioning, and the rate of comorbid major depression. However, significant differences were found between men and women in terms of the frequency of certain comorbid disorders, including, and these are things that could also be diagnosed side by side. Post-traumatic stress disorder, 51% of women versus 31% of men. Eating disorders, 42% of women versus 18% of men. Substance abuse, substance use disorder, 58% women, 85% men. Antisocial personality disorder, 10% women versus 30% men. Narcissistic personality disorder, 5% women versus 22% men. And schizotypal personality disorder, 10% women, 25% men. I think that there are clear patterns when we look at this, when we think about psychosocial perspectives that I really find fascinating, but I'll spare you for now. And so, among patients with BPD, unstable self-image, sense of self, was present in significantly more women than men, about 67% versus 48% of women. So, there are some other considerations as well. Religion, especially when it comes to ritual or self-harm. This may seem like a stretch to some people, but we really have to remember that, many religions also require self-harm to be a part of them in some way. And so these are things that we need to think of, especially when we're having that conversation about people, immigrating, traumas, just the whole process. So, even when we think there's the religion piece, and then when we combine it with, possible assimilation and the need for larger conversations around what it means to be in a new culture, there's just a lot there. So keeping in mind that there are some different rituals involved in different religious practices. Public grief and mourning. I put here an example to remind myself to bring up the Chinese. The Chinese typically believe, to really hold in a lot of emotions, but when it comes to mourning, the death and grieving, it's a very public process for them. So I think that that's something that we need to be thinking of as well. So how just different, all these different ways that different cultures think and function and feel what it is that they're going through, so that we don't mistake something for something else. General views about mental health must be considered. Some cultures see it as a weakness. Some don't even believe it's real. So there's all of these pieces that we have to think, if somebody's sitting in front of us, what those messages were when they were growing up. And cultural passivity could be mistaken for depression. So if you are if you're coming from a culture that is very passive, that you're not very engaged in your own existence, your own life, it's not very individualistic, or it might be more communal, you might see, we might mistaken that for depression, when really it's just practice, just kind of a practice. I think a lot about people who meditate a lot, because I really think that, when people can, maybe be a little more quiet or a little more reserved, it makes some people uncomfortable, because we have different expectations, particularly in our American culture. And so we need to be taking those things into consideration as well. So, cultural passivity and the diagnosis of a personality disorder, as well as the very definition of what constitutes a normal personality, is entirely a cultural and social construct. And so, the thing to remember is with social constructs, is that there are still very real consequences to these constructs. So, they are real in that they have real consequences. However, we have to remember that, a lot of these disorders. Are deviating from a norm. And so we have to interrogate what that norm is and really think about not only what we think of that norm and how we kind of align or do not align with that norm, but how might our clients be seeing that norm? How might they be aligning themselves with it? How may it help them? How do they feel like it might be helping them survive? How do they feel like it might be preventing them from being who they really are? There's a lot of pieces there when we think about what a normal personality disorder is when we're talking about personality disorders as a whole. So culture plays a role in the definition of the self, in the expectations on the orientation of the person, so towards the individual or the social group, and in the definition of how a normal personality is constructed and expressed in itself. Therapists' views on post-racial or color blindness in any internalized oppression need to be considered when we're thinking about this, especially when we're talking about personality disorders, especially when we're talking about trauma, because there's so many layers to that and how that comes to be. And so, finally, we're going to go into treatment modalities. But first, I'm just going to talk quickly about some ethical considerations. So I kind of wanted to separate the cultural and ethical piece just a little bit for more clarity. And I wanted to talk about it specifically around what it would mean if you had a suicidal client or a client with suicidal tendencies or thoughts, ideation. So I just thought about 5 ethical questions that arise for therapists that therapists should consider when they treat patients with borderline personality disorder who may be or are or were suicidal. Talking to patients about their diagnosis can feel very unsure. I did, in the video that we watched, it was great because they did address that, diagnosis, at least from what I've read so far, is usually welcome, greatly welcome, because it's like, okay, at least now I understand this, at least there's a thing here. But again, when we think about cultural implications, may not be the case. We should also be thinking about, what they should tell them about their suicide risk. So how to have that conversation about suicide with your client. There's not necessarily like one way to do this, so I'm not here to tell you any of that. I just want everybody to just kind of have these things in their head, that these are some places that can get tricky, especially depending on your client. And when we're combining those ethics, especially with the cultural implications. For some people, it might be welcome, and for others, not at all. And suicide in and of itself, very hard conversation to have, obviously, anyway. So another one is whether they should always be available. Boundaries are so important here. How to make yourself available is a question when you're talking about borderline personality disorder, especially because people are going, how you're creating that therapeutic relationship with your client and being the example. How do you do this? What does a healthy relationship look like? All of these things you have to consider when you're talking about borderline personality disorder. So it's very important to think about this. So are you going to always be available? What are your hours? How are you just allowing the communication to exist? And when you're talking about suicide, it's a very hard choice, right? Because you're always going to think, I didn't answer the phone or whatever. So these are ethical considerations that are also very hard decisions to make. And people and lots of therapists, I'm sure, make lots of different choices. The other thing is when you should hospitalize a patient involuntarily. That's something that can also get, the lines can be a little blurry. So, keeping that in mind, and how you should respond after patients have attempted suicide in return for further care. So if that's happened, they've been hospitalized, they return to you, how does that relationship change? And in what ways does it stay the same? And so an example, I put here just kind of this duality is, therapists could share whatever the dilemma is, insert dilemma above where I have these implications, with patients with borderline personality disorder. They could say, for example, that they want to share the information with the patient so that they can face this, increased risk together. We're going to do this together. We know that we have this thing, we're going to get through it. But I have psychiatrist here, sorry, it's a typo, might also add that they fear this information might have a negative effect on a patient by reducing their hope. And so it's like, how far do you take it? How much of a conversation do you actually have? It's challenging. So, with that being said, we're just going to do some treatments here and talk about treatments. Some quotes I have, if you're always trying to be normal, you'll never know how amazing you can be. Maya Angelou said that, and this is a quote that I see often popping up in my research that people are using. And I think that what they're trying to do too is draw that connection between that, what is a normal personality anyway? How do people determine when they have borderline personality disorder or any personality disorder, what parts they want to keep of themselves and what parts they maybe don't want to keep. This is not a conversation really about, you need to change into this whole entire different person. Because even though it can be very hard feeling so much, there's also a lot of empathy that can come out of those perspectives once it's worked on with somebody. So there's a lot there to sort of to think about. And another thing is, I don't know what it's like to not have deep emotions. Even when I feel nothing, I feel completely. And I thought that was a great quote as well. The author was unknown. However, they did, I'm sorry, this is like acting up. However, they did say that. So finally, treatment. So the upside of BPD is that it can be healed and it can go into remission. This was something that I did not really know. I was very happy to hear this, that there is a very high rate of healing from this. The downside is that there are often a lot of co-occurring issues, and treatment can be really difficult because there are so many other things to consider with borderline personality disorder. It can definitely seem quite overwhelming, which would explain why there are a lot of therapists who focus on this specifically. Like, we do borderline personality disorder or personality disorders, and that's it. We don't even touch anything else because it is a lot in and of itself. Therapists often recognize bipolar symptoms and BPD symptoms, which can create quite a dilemma. This is why screening as well as other cultural considerations are so essential. Diagnosis can be a great relief, like I said, but it can also not be if we're not considering the broader picture. Psychotherapy is the preferred method of treatment, and to decrease, eliminate, alter the behaviors and improve adaptation to living with this. This is not something that goes away. It does not go away. It's just something that's learned. You learn to adapt. You learn to keep what you want. My mom always said, keep the meat, cut the fat. And so you're kind of doing that in terms of all of these behaviors that you've built up over time. So CBT, it's important to remember CBT, there's a lot of like CB terms. So I just wanted to clarify. CBT is an umbrella term for a group of therapies. Is the combination of both cognitive type of therapies and behavioral therapies. It's the combination of those two things. And so under that, there are many other therapies underneath the cognitive behavioral therapy window. We often think of CBT as just, it's CBT, it's one thing, but it really is so many other things. So MBT, which is mentalization-based therapy, it's an integrative form of psychotherapy, bringing together aspects of psychodynamics, cognitive behavioral, systemic and ecological approaches, and it was developed by Peter Fonagy, probably Fonagy, and Anthony Bateman, designed for individuals with borderline. So it is the treatment that was made specifically for borderline personality disorder. For a straight diagnosis, this is usually where people go. Here, cognitive psychology and attachment are combined. And so it's, you're thinking about cognitive psychology, and you're also thinking about attachment theory, because there's so much in borderline personality that has to do with attachment. And there's a focus on neurophysiology, and what your brain is doing is really important in understanding borderline personality disorder. Cognitive therapy fits underneath there as well. DBT, which we talked about, the dialectical behavioral therapy, which is extremely helpful, fits under that also. But that would be considered, I also have it here, because I wanted to talk about third wave CBT, which is, at least from what I've been exploring, it's sort of like the new wave. It's really where we are now. It's probably not even that new anymore, but it's really just where we are now, which is a little bit of a different approach than we have had historically. So connected to the cognitive behavioral therapies described above, third generation forms of CBT, also referred to as the third wave. The above mentioned forms of cognitive therapies are mainly, or in this case, the below mentioned, are mainly concerned with behavioral modification and change, particularly as it relates to anxiety, fear, and depression. You see, they're starting to think about, not just CBT, but the whether it's borderline, the things that we use CBT to treat in a broader way. We're not just looking at it sort of in this vacuum. We're really thinking in a much broader way, and multiple, all of these different sort of symptoms that come out of that. The third wave of CBT focuses more on wellness, strength-based components that place an emphasis on mindfulness, acceptance, alternative controls, alternative coping mechanisms. In many ways, these forms of CBT reject the sickness model. We're not talking about somebody who's sick and needs to be hospitalized or criminalized. We also saw this, I think, play out when we had this conversation when we were talking about John Nash as well and schizophrenia. It's the same thing. These are not, we're starting to think about, whereas in the past, somebody would just be locked up, which is criminalized in a lot of ways as well. But now we're really trying to take that, reject that, sickness model of mental health, and really embrace how, acceptance and coping and compassion. And so CAT, cognitive analytic therapy, fits under this third wave CBT, DBT as well. When I think of DBT, I think of radical acceptance. That's really a lot of what dialectical behavior therapy is doing. And then there's some others that you may or may not have heard of, but ACT, CIP, MBC, ICTB, all of these things are kind of different forms of CBT that fit under this sort of third wave model, pieces of which you may or may not use in the treatment of borderline personality disorder. And then finally, hospitalization in some cases is necessary. And so that is certainly a piece of treatment should be necessary. And there's other things to keep in mind that I think are important that I learned in this process as well, especially when you're dealing with self-harm. And if somebody's sitting in front of you, they talked about how, instead of cutting or you're in a therapeutic session, you could hold ice cubes in your hands. There's all kinds of sort of tricks that, exist for people who would need to deal with wanting to self-harm in a session because of the intense anxiety and the feeling of the loss of control in that space. And so there are things that you can do to help them to focus. So I appreciated that trick. And finally, just little things to remember that BPD is also not dissociative identity disorder. I think that's a really important thing to mention because I also noticed that there was some concerns in the research that people were often mixing these things up. So I just wanted to bring it up. It's not the same thing, very different things. So keep that in mind. Bipolar is not a personality disorder. It is a mood disorder. This is important because, again, these things, they can be co-occurring, but also these two things are often put in similar categories, which means we have to be very clear on what both of them are. Society's views of those with BPD are cruel at best. Just in the process of doing this assignment, Googling, reading, there's so much here, but when you're not looking at academic writing about this or experiences firsthand of people who are suffering from BPD, you're reading a lot of your girlfriend's crazy and she has BPD, how to tell, why never to talk or be friends with somebody with BPD. It's just, the internet is flooded with horrifying articles, that are definitely fake news, but really everywhere. And this is the kind of stuff that people with this are going to be reading, and it might, be, stopping them from going and getting the help that they need, as well as, their partners just deciding, or their friends just deciding that they're absolutely worthless and they have no future and they should just, stop. And so, that's something that was challenging to see. So the other thing was just the prefrontal cortex, this space that has to do with order, which is sort of like underactive when we're talking about borderline. And then the amygdala, which is the emotion part of your brain, is overreactive. And so really understanding that what the brain is doing and how it's been programmed, a lot like we talk about PTSD, right, in those ways as well, is also happening. There's a lot of brain activity or underactivity that should be considered when we're thinking about BPD. And finally, I swear, be compassionate and remember that people recover from this. And with that being said, I really appreciate you all hanging in there with me. I know that this is a lot. Believe it or not, I had even more. So I appreciate you getting through this entire presentation. And I hope you have a fantastic summer. And thank you so much for learning about borderline personality disorder with me. All right. See you later. Take care. Bye.